Order. Good afternoon, and thank you all for joining us for today's hearing, Maximizing Access and Resources, an examination of VA productivity and efficiency. Today we will discuss clinical productivity and efficiency in the Department of Veterans Affairs healthcare system. As a clinician and a veteran, this is an issue I hold near and dear to my heart. As one of our witnesses, the Government Accountability Office, will note this afternoon, VHA's bottom line has grown significantly over the last decade, increasing from $37.8 billion in fiscal year 2006 to $91.2 billion in fiscal year 2016. As a federal agency, VA has an obligation to be a responsible steward of the taxpayer dollars that so generously fill its coffers. As the federal agency responsible for providing health care to our nation's veterans, VA has an obligation to be a responsible servant worthy of caring for the greatest fighting force the world has ever known. However, it's not clear whether or not the increasing amount of money that has been allocated to VHA has resulted in a more productive, efficient health care system or in veteran care that is more accessible, more high quality, or more cost effective. And that's our goal. This afternoon, we're going to examine findings from both a recent GAO report and from the 2015 independent assessment, which will detail a variety of concerns with clinical efficiency and provider productivity at VA medical facilities. For example, we're going to hear how the current models and metrics that VHA uses to assess clinical efficiency and provider productivity fail to account for all providers and services, fail to accurately reflect the intensity of clinical workloads and staffing levels, and may be populated with inaccurate data, as well as how VA central office policies and procedures fail to provide sufficient monitoring and oversight even when problems have been identified. We'll also discuss how VHA's productivity compares to leading private sector healthcare systems and what industry best practices VHA may be able to use to increase quality and efficiency. For example, we're going to hear that the number of patients assigned to VHA primary care providers is 12% lower than the private sector benchmark for patients of a similar acuity. Which all begs the question, what are we paying for? To be clear, VHA is taking strides and making progress, and not all of barriers to increase productivity and efficiency are under the control of the individual VA medical facilities or providers. As we discussed during yesterday's full committee hearing on VA's capital asset deficiencies, the average VA medical facility building is 5 times older than the average building in a not-for-profit hospital system in the United States, and is not well situated to the provision of high-quality care or to efficient practice of medicine in the 21st century. As a doctor myself, I know firsthand the constraints that are placed on a provider who lacks sufficient clinical space and adequate support staff. In the private sector, room-to-provider ratios are typically 3 or 4 to 1. In the VA healthcare system, providers typically only have a 1-to-1 room-to-provider ratio, as well as significantly fewer nurses and administrative staff. So that means in many cases the deck is stacked against a VA doctor the second they step into their clinic. We need to find solutions for those providers, for the taxpayers whose hard-earned dollars are supporting VA's massive bureaucracy in increasing frequency, and most importantly, for the veterans who deserve a more efficient, accessible VA healthcare system. I will now yield to Ranking Member Brownlee for any opening statement that she may have.
Thank you, Mr. Chairman. Paired alongside yesterday's hearing on capital asset management, the topic of VHA productivity and efficiency is both timely and vital as we discuss VHA's ability to care for our nation's veterans in the future. Yesterday, former Secretary Princepi stated he did not believe VA would survive another decade of capital asset constraints on the scale we see now. I couldn't help but think of how this issue of provider productivity and efficiency ties directly into the issues we see with capital asset management at the VA. As Ranking Member Waltz and Chairman Winstrup mentioned in yesterday's hearing, it is crucial that VA be able to accurately determine the capabilities of its staff when determining the fitness of its infrastructure. I'm concerned that VHA does not have the tools necessary to make this determination. Even more concerning is the idea that VHA is relying on faulty productivity and efficiency data while shifting significant resources, including taxpayer dollars, into the community and away from VHA facilities. It is difficult to believe VHA is confident in its multi-billion-dollar budget request for fiscal year 18 when it is increasingly evident VHA does not have the tools necessary to make decisions using proven processes that are based on sound data. In its report, GAO made many recommendations similar to those made by Grant Thornton in its 2015 assessment of VHA's productivity. While VA has concurred with these recommendations, I'm curious as to why they were not addressed immediately following the assessment by Grant Thornton. If the same issues are being raised repeatedly by multiple parties almost 3 years apart from each other, I do not think VHA can boast of its progress in addressing the issues. I understand that some of the recommendations made by Grant Thornton and GAO are difficult even for the private industry to address, but VA has a track record of leading the healthcare industry, and I will continue to hold VA to that standard, the standard of an industry leader. I am hopeful VHA will take the issues raised during this hearing seriously, and I hope my colleagues and myself are able to support you as you address these issues in a timely manner. While the adoption of a new generation electronic health record system will assist in accurately collecting workload data, VA's capital asset portfolio will not wait the 8 or 9 years it will take for VA to set up the new electronic health record system. Therefore, this new system cannot be the excuse VHA uses to further delay the implementation of both Grant Thornton's and GAO's recommendations. During today's hearing, I hope to learn more about this issue so that I can support VHA in its efforts to develop an accurate and useful system that promotes the productivity and efficiency of VHA's healthcare providers. Thank you, Mr. Chairman, and I yield back.
Thank you, Ms. Brownlee. Unfortunately, at this time, you heard the buzzer. They have called us over to votes, and I hate when this happens. We are going to have to go to votes, and I'm going to ask you if you would please stay nearby, and we will come back and continue on after the vote series that is taking place right now, and I appreciate your patience on that. Thank you. I'm going to take a liberty because we have a time constraint on this room. Before I introduce you, if I give you a minute or two to prepare, rather than 5 minutes for your opening statement, if it's possible, that we could reduce them to 3 minutes, and then we will have adequate time for questions, if that's okay. I'd like to proceed in that direction. So joining us on our first and only panel is C. Sharif Ambrose, principal at Grant Thornton, LLP, one of the authors of the Independent Assessment, Randall B. Williamson, healthcare director from the Government Accountability Office, Dr. Jonathan Perlin, former Undersecretary for Health and now the President of Clinical Services and Chief Executive Officer of Hospital Corporation of America, and Dr. Carolyn Clancy, Deputy Undersecretary for Health for Organizational Excellence, who is accompanied by Dr. Murray Altos, the Chief of Staff of the Lewis Stokes Cleveland VA Medical Center. I want to thank you all for being here. And Mr. Ambrose, you got the short straw, I guess. We'd like to begin with you, and you're now recognized for 3 minutes, but having you go first, if you're over a little bit, I think we'll be okay with that. So you're now recognized.
Thank you, and good afternoon, Chairman Wenstrup, Ranking Member Brownlee, and members of the subcommittee. Thank you for the opportunity to discuss Grant Thornton's 2015 report on VA provider staffing and productivity. My name is Sharif Ambrose. I'm a principal at Grant Thornton, where I lead our public sector healthcare practice. And we provide consulting services to government clients, including the Department of Veterans Affairs, and it's been our distinct privilege and honor to support the U.S. Department of Veterans Affairs and the veterans it serves for the past 20 years. I'm accompanied by my colleague Eric Shannon, who leads our commercial healthcare advisory practice, who also contributed to this assessment. CAMH served as the program integrator and as primary developer of 11 of the Veterans Choice Act independent assessments. CAMH is a federally funded research and development center operated by the MITRE Corporation. We conducted our assessment in 2015 of current provider staffing levels, caseload, and productivity in comparison with healthcare industry benchmarks. Our findings, among our findings in assessment G, there's a couple I'd like to share with the committee. First, we found that VA doesn't systematically track fee-based provider productivity and does not capture the FTE level information for fee-based provider care providers. We also found that staffing levels per patient population were in most specialties lower than the industry ratios. The ratios, however, are not sufficient to establish whether VHA is staffed to meet demand because of factors that make it difficult to measure clinical workload at VHA and to compare to industry benchmarks. Further, we found that the number of patients assigned to VA general primary care providers is 12% lower than the private sector benchmark for patients of a similar acuity. And with respect to specialty providers, our analysis showed that VA specialists are less productive than their private sector counterparts on two measures: encounters and work relative value units, otherwise known as WRVUs. We studied root causes, and our team examined many of them that drives VHA provider productivity and found several factors that limit the ability of providers to optimize productivity. First, we found that VA providers have a lower room-to-patient ratio than their private sector counterparts. Room-to-provider ratios in the private sector are typically 3-to-1, and we found that VA providers typically only have a 1-to-1 ratio, which doesn't allow them to see as many patients as their private sector counterparts. Similarly, VA providers have significantly fewer nurses and administrative support staff, which means the providers can't be as efficient as they otherwise could be. We outlined many recommendations in our report. First and foremost is that we recommended that VA evaluate the design and implementation of their staffing models to which they are sufficient to ensure all eligible veterans have access to high quality and timely care. I think I'll yield my time in the sense of time to the other witnesses. Thank you.
Thank you. I appreciate that. Mr. Williams, you're now recognized.
Thank you, Chairman Winstrup and Ranking Member Brownlee. VA has developed productivity metrics to measure physician providers' time and effort to deliver procedures and methods to track clinical efficiencies at VAMCs. Using the metrics, VHA's Office of Productivity, Efficiency, and Staffing, or OPES, reports data on each VAMC for VAMCs to use in identifying suboptimal clinical productivity and efficiency. GAO's recent study in this area identified limitations with VHA's metrics and methods that limit VHA's ability to assess whether resources are being used effectively. Regarding productivity, there are several needed improvements. First, while OPES reports provider productivity data for 32 different clinical specialties, the data only covers VA-employed providers. It excludes contracted providers that work at VAMCs and others such as nurse practitioners who are other major contributors to patient care. Also, VA providers are not always accurately coding the intensity of their clinical workload, that is, the amount of effort needed to deliver the procedures they perform. Finally, VAMC providers may not always be recording their clinical time accurately. To its credit, VA has implemented or is developing new initiatives to improve productivity and efficiency data. For example, they have intensified training for providers in the field on proper methods for coding, and they're attempting to solve other staffing issues as well that relate to labor mapping. GAO made recommendation to further improve productivity and efficiency data, and VHA has concurred with all of them. Perhaps the most significant issue from our study centers around VHA's lack of oversight and monitoring to better ensure that VAMCs with suboptimal productivity and efficiency are held accountable for making substantive improvements. Currently, VAMCs with suboptimal productivity are required to develop remediation plans and submit them to their respective VISNs for review. However, current VA policy does not require VISNs or central office to monitor VAMC's implementation and resolution of these plans. Moreover, VAMCs are not required to address or monitor their overall efficiency at all, and as a result, they do not develop remediation plans to address inefficiencies identified by OPES data. Our review of data shows that some VAMCs perform poorly on these metrics year after year, and there appear to be few real incentives for VAMCs to improve these metrics. In summary, achieving better productivity and efficiency will better ensure that VHA is using resources wisely and maximizing access to health care services for veterans. Thank you, Mr. Chairman.
Thank you very, very much. And Dr. Perlin, you're now recognized for 5 minutes.
Thank you, Mr. Chairman, Ranking Member Brownlee, and we thank Chairman Rowe and members of the subcommittee for the opportunity to be here today. HCA is the largest private provider of healthcare services with the privilege of about 28 million patient encounters annually. We have about 241,000 employees, including 80,000 nurses, exclusive of another 37,000 voluntary physicians. And we have the privilege of seeing patients at 168 hospitals and 1,200 other sites of care. So roughly speaking, we're similarly sized to VA. We also proud to acknowledge that included in our dedicated workforce are many veterans and military spouses. And in the last year alone, we hired more than 5,400 military veterans and 1,100 military spouses. And that led in 2015 to the Chamber of Commerce Foundation's award for hiring our heroes, the Lee Anderson Veteran and Military Spouse Employment Award. On that basis, on the basis of my history in VA, I believe that I have a unique perspective to offer on this particular topic, having served as Undersecretary, Deputy Chief Quality Officer, and like Dr. Shulkin, in his current and previous capacity, actually seeing patients in VA. I note Dr. Shulkin's 100-day briefing at the White House, where he offered a number of observations that he came to from a business and clinical perspective, and I'll note 3 that I believe are directly relevant to GAO's assessment of VA productivity. Dr. Shulkin's first diagnosis of risk concerned access. His comments identified substantial progress overall, including same-day access for primary and certain specialty services, but also identified remaining opportunities for improvement. Obviously, increases in provider efficiency are an important means for creating additional capacity and access. His second diagnosis of risk concerned prompt payment of external providers. This is an area in which legislative relief would be helpful. Consolidation of disparate models for obtaining services outside of VA, and frankly, comportment with Medicare or private insurer reimbursement models would facilitate provider participation and increase veteran access to services. The complexity of the different VA models imposes statutory inefficiencies on VA's overall management of care both within and outside of VA. The third area noted by Dr. Shulkin was quality, and VA is to be commended for making their star ratings public. VA is increasingly benchmarking against private sector, and in many instances, VA performance is as good, if not better. And I note in particular areas, these areas because they're salient to the comments on productivity within GAO. GA notes, as Mr. Williamson said, that productivity metrics are not complete, and the new information system should provide a resource for capturing workload. This is a perennial challenge, as is the attribution to particular providers, and this is well demonstrated in the history of attributing performance metrics around quality and safety. I would note that in our organization, when we think about the care of hospitalized patients, rather than trying to capture every individual action, we summarize by looking at things like employee equivalents per occupied bed. GAO also notes that intensity of service may not be quantified. That's something that's incentivized more in private sector because it calibrates to a reimbursement. So on the basis of my experience with VA management systems of more than a decade ago and my research for this particular hearing, I would note that VA Central Office has taken steps to help VA MCs monitor provider productivity by developing tools to oversee performance and efficiency. VA and HCA share a strategic and operating advantage in that scale, and within that scale is the capacity to look for not only negative, but also positive variation. If the underpinnings of better performance can be understood, replicated, and scale, becomes the means to elevate the performance of the entire system. So understanding variation within the system in comparison with external performance standards is really why both internal and external benchmarking is necessary. Internal benchmarking is a tool for learning and management. It can function as an important control system for facilities, for VISNs, and for VACO leadership to manage performance. External benchmarking is necessary to understand whether internal performance is superior, consistent with, or inferior to external organizations. External benchmarking is limited by differences in data availability and data definitions, but I'd note that the biggest challenge to external benchmarking is not related to data, but rather certain inherent features of VA and the patients it served. First, veterans using VA are systematically more complex than commercially insured or even mixed commercial government patients, and so benchmarks need to be calibrated to that increased complexity. Second, the VA benefits package is systematically different than either commercial insurance or other government programs like Medicare or Medicaid, and there are many more things that VA providers can, should, and really must do to care for veterans appropriately. Indeed, in a capitated system, it's rational to take all necessary actions for preventive services or other interventions that reduce the need for future services or subsequent interventions. Again, there's this tension between work and recording of work. Third, RVUs were developed in fee-for-service environments and really do calibrate recorded work with compensation. In point of fact, it's not only about efficiency, but recording quality in our organization. We always look at productivity and compensation together only with quality, which is the non-negotiable foundation. Fourth, in our organization, in our physical plants, and as you referenced, the ranking member referenced in your statements, the VA physical plant doesn't support multiple exam rooms, and this compromises the ability for the most efficient care. Finally, I would note that, as you noted as well, that there may not be as many supportive staff, and there are times when it may be inefficient or inappropriate for VA to produce all of its care internally. And in this respect, I agree with the Secretary's perspective to use private sector services when geographic access, wait times, capacity, demonstrated clinical performance excellence, or technology are not available in VA. Let me close with the comment that looking at quality is obligatory. Quality and safety are always the most efficient. Rework for breaches in either is neither efficient nor consistent with the performance excellence that taxpayers deserve and that veterans should expect and certainly have earned through the service and sacrifice. Thank you.
Thank you. Just under 3 minutes. You barely made it. Dr. Clancy, you're now recognized.
Thank you. Good afternoon, Chairman Wenstrup, Ranking Member Brownlee, other members. Very happy to be here. I'm here with Dr. Murray Altos, who is the Chief of Staff from the Cleveland VA Medical Center. Let me just reiterate that our top priority is improving access to care for our veterans, and improving productivity and efficiency is a means to that end. As the others have noted, we have developed a pretty sophisticated tool that is calculated in industry-based resource relative value units. And this is used widely across our system, and we can actually see that by the number of web hits. We've seen an increase of 37% in the past year in terms of the number of people actually looking at this. Getting to optimal productivity and efficiency is, by definition, a team sport, where deployment of providers is continuously evaluated and revised, and there's a very strong collaboration between the clinical workforce and the administrative function. As others have noted, we implemented clinical productivity metrics in 2013 and have developed statistical models to track efficiency at our medical centers. We have designed reports to provide our leaders in facilities and networks with essential tools to understand which clinics are working under, at, or over capacity. And we have something called the Spark tool that I know you have seen, Mr. Chairman, which actually gives our leaders a sense of whether clinics are working under, at, or over capacity. Since the tool's introduction, as I noted, we've measured reportable progress as demonstrated by increase in RVUs. Our system-wide focus on improving access to care, prioritizing urgent clinical needs, and achieving same-day access for veterans with urgent primary care or mental health needs has resulted in a 13% increase in clinical workload with a concurrent increase in RVUs per clinical employee of 9%. Specialty practices that are not meeting productivity are required to develop remediation plans. And in fact, there is a monthly meeting between clinical operational leadership at central office with the network, with those who are reported as outliers using statistical trigger tools. We have concurred with the GAO recommendations and are already working to complete them. I want to make note and really recognize my colleagues who developed data to assess the clinical productivity of advanced practice providers several years ago. In most of healthcare, the work of those providers has been subsumed under the billing done by the clinicians, physicians with whom they work. So we will be setting performance standards for those providers in the very near future, and I believe may become actually the reference for other systems because of expanding full practice authority. Thanks to the Congress, the group practice managers that we have at all of our facilities now oversee staff and clinic flow, I think has been one of the most exciting developments in our system. They are charged with specialty practice management and have quickly and adroitly begun addressing the myriad issues in optimizing clinical practice in real time. Our best facilities, Cleveland would be one, have established a regular rhythm with close collaboration between the group practice management, the chiefs of staff, the service chiefs, and so forth, and they are constantly conferring about how to do better. And with that, I think I will simply conclude my remarks. We find the GAO's recommendations helpful. We've made progress, and we'll continue to move in that direction.
Well, thank you all, and I'm going to take some time now for me to have 5 minutes for questioning, and I appreciate you all being here. I can tell you that a lot of the ideas that I hear coming out of today are greatly appreciated, but to be honest with you, there are a lot of ideas that I and other members of this committee have been talking about and asking to be implemented since I've been here, which is 5 years, which is 2013, for example, with metrics. And even as of this week, when I asked about RVUs, being able to measure RVUs, I'm told, well, we don't have them for everybody. And today we heard that contractors are excluded. This is not the way to really, in my mind, develop some understanding of what is taking place. If we set up metrics, we should be able to set up metrics to evaluate the VA healthcare system in general, each visit, each hospital, each facility, CBOC, each practitioner for that matter. And it's a matter of simply training people to know how to code And my first question is, are our providers not able to code the way that private practitioners do so that we can track RVUs? It's a relatively simple system if you know how to bill and how to code what you have done. Is that missing from our healthcare system in the VA?
Many of our providers are quite good at it. I would almost expect certainly that they are less good at it than private sector providers because they don't have the same direct billing incentive, and we don't have the same number of expert coders on the ground locally. So with that caveat, some are better than others, and we are committed to training those who are having more trouble.
Across the board, contractors and everything.
Contractors we have a little more trouble with because the nature of our contract is that we are not paying for their time. We are paying for the services they produce on a fee-for-service basis. So we're not actually hiring someone to work a full day in the clinic or half a day.
Well, then if they're on a fee-for-service basis, they know how to code.
Yes, exactly.
Okay, so they don't need the training.
Exactly.
They already got it. So you mentioned, Dr. Clancy, that those that are suboptimal, they have to present a plan. How can they present a plan if they don't know what they don't know? I mean, it seems to me that a plan should be delivered to them. Someone should be assessing their clinic and say, hey, you know what? This 1-to-1 ratio doesn't work. Maybe they don't know that if that's all they've ever seen. Why are they developing the plan when they're already operating in a system that's doing wrong? I would love to have their advice on how they can get it better, but why are we waiting for them to develop a plan? Shouldn't we be giving them the plan? We would do that in our own practice. If one's producing more than the other, and we are always concerned about quality, that is you got to concede that for sure. But hey, this doctor has 2 medical assistants. You only have 1. And they're seeing twice as many patients and delivering the same quality. So the plan needs to probably come from someone else who's had some success.
Well, the plans have to be signed off on by their service chiefs. So this is not just asking someone who's doing a bad job to tell me how can you do better, okay? Yeah. Secondly, as I think you're aware, many of our facilities, and you referenced this in your opening remarks, are very much space constrained. Having 3 or 4 rooms to work with feels like, something from Star Wars, but most of the
My question comes in, though, really, or my concern is, who is providing the guidance and creating the plan so that they are more productive? That I think we have to talk about, because you said that they submit their own plan. Well, they're not the experts, obviously, if they're suboptimal. You need someone who knows how to be optimal to create the plan,
Without
in my
question,
opinion.
yeah. The guidance is 2 parts. One is technical in terms of what do these trigger tool means and what do your metrics actually mean, so that they can understand the delta that we're seeing, particularly if they're not actually all that familiar with it. But the real guidance is operational leadership, and I might just ask Dr. Altos to chime in on that.
So I would offer that the agenda that's offered to the facilities by central office, I think, is reasonable. The priorities are set. The resources are distributed. The oversight does take place. The big issue, in my opinion, is simply operations at the local level. Mm-hmm. And it's complicated because, as has been pointed out in much of this testimony, there are many parties who contribute to the provision of care, both on an ambulatory basis and in the hospital.
So this leads to my next question when you talk about incentives. I'm not been made aware of incentives for quality and productivity that are measured, that are there. And you said you're working on that. I'd like to hear some of your ideas, and that's my last question before we move on.
I can also speak to that and point out that, particularly in an ambulatory setting, efficiency and productivity is based on a team effort that involves schedulers, clerks, providers, nurses, technologists, and each and every one of those parties need to be able to contribute, and one aspect lacking is going to seriously compromise efficiency and productivity. Reward needs to be offered not to individuals, but to teams. This is a team effort. It requires an effective team, and rewards need to be distributed to the team, not necessarily to any one individual.
I would agree with that. Ms. Brownlee, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I wanted to go back to my opening comments that I made, and this question is for Dr. Clancy. And I mentioned in my opening comments about in the current GAO report, they've made many recommendations that are similar to the Grant Thornton report and that took place in 2015. The VA concurred with those recommendations, at that time. So I'm curious as to why they were, we're now in 2017. That was 2015. Why haven't we met those recommendations of which you said at that time? I believe that you concurred and would work towards, and now you're saying you're going to work towards the GAO recommendations as well. So it's a lack of budget, tools, what?
I think one of the biggest critical gaps for us has been getting the right people into key leadership positions. I mean, at our best facilities, this culture and strong sense of it's a team sport starts from the top. And it was one of Dr. Shulkin, when he was Undersecretary's top priorities, was to make sure that we filled critical gaps in leadership across our system. Some of those are only recently filled, but we are in so much better shape since he started at VHA. And with our system, that took time to get the right people into their seats. Meanwhile, at every level, we are seeing much more attention to the technical tools. So the two game changers, I believe, are the full practice authority for advanced practice nurses, and also we've already got the tools to know how much they are contributing in terms of RVUs. And the second is the group practice managers. Now, getting that practice up and all those slots filled, I would say, has taken over a year, but we are now at full or very close to 100% capacity there. They have been trained in what is essentially a new role in our system, and one that I think is very, very important. That's why I was expressing our appreciation to the Congress for insisting on this, because trying to figure out exactly what this person was, how they would fit in the existing system, did take some time, and it took some training for them to understand how they would be doing their jobs. But I think that we are beginning to see the benefits of that now.
Thank you. And I also wanted to follow up with you on, I think in your testimony back in May of 2016, the VHA's Health Information Management Program Office developed and implemented training for providers to improve coding accuracy. So have all the providers now received this training?
They have certainly all been offered. I would take it for the record to tell you exactly what proportion. As you know, in our system, we have some regular turnover among providers, but we are committed to reaching those, A, who haven't been trained or have somehow missed the opportunity, and B, are not doing so well. That is going to be our first priority focus, rather than a blanket across the board for people who are already doing a good job.
So just so I understand, so the people who have been on board and have not, you talked about the churn, and I get that, that's that piece of it, but are you talking about just the churn not having been trained, or still others in the organization that haven't been trained?
Well, in some of our organizations, we have people who are effectively working part-time because they've got split appointments with academic affiliates. They may have teaching responsibilities and so forth, which is also another factor in considering how our productivity stacks up against the private sector. Do they have those same missions or not? And I wouldn't be shocked to know that some of them may have not taken full advantage of the opportunity to be trained, and we will be making sure that everyone gets it.
So, and then once a provider has been trained, then how are you holding them accountable to
Again, this is a regular review, and we are reviewing centrally in terms of who are the outliers. Right now, for example, our best estimate, or at the end of 2016, was that 14% of our specialty practices are under capacity, working under capacity in terms of productivity. And then there's a question of diagnosis. Is it that the physicians are not doing their best work, or is it, as in one place I visited, that there are no schedulers, or almost no schedulers, to schedule patients for them to see, which obviously would be a problem, and so forth. So that is how we're putting this all together.
Thank you. And may I have another minute? For HCA, in your testimony, you state that accurately capturing the workload of providers who managing the care of hospitalized patients is difficult, even in the private sector. In order to mitigate the administrative burden of providers, you recommend that workload be captured as a byproduct of work. And I guess my question is there a system in the private sector that the VA could look to or purchase off the shelf that would achieve the sort of accurate capture of this information?
Thanks, Congresswoman. That's a terrific question. The systems, the electronic health records used in private sector are really optimized for the coding efficiency. In point of fact, it takes much of the burden for coding off the provider and allows, frankly, less expensive, more efficient people to code behind the scenes so that the provider is taking care of patients and the coders are coding. So I think there's a workflow issue that could be used in the near term. In the longer term, recognizing the chairman's comment that didn't want to wait until the full replatforming, as VA does replatform, I suspect that that system will have many of those tracers embedded so that workflow can be captured as a byproduct of work rather than counterproductive additional work.
Thank you, and I yield back.
Dr. Dunn, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I want to note that this particular topic, productivity, efficiency, quality, are these determine value, and this very subject is going to occupy the attention of this committee, and I think the larger committee, as it has for years. It's going to be a real focus going forward. We're going to try to finally find the light on this subject, I hope. And I'm grateful, by the way, to have such an august group of consultants that we can ask for input on this difficult subject. Mr. Ambrose, your findings between the productivity of private practitioners and the VHA were intriguing. And then they're able to measure productivity with the cost of deliverables. And the cost of delivering, this is like the cost of delivering an office visit, surgery, drugs, and so on. Do you agree that this is a rational and effective way to measure productivity?
Well, thank you for the question, Congressman. If I understood your question correctly, cost is certainly a component, both at the episodic level as well as the patient level, that should be looked at. And I believe VA has the ability to measure costs, just like other provider systems do. We did not in our study.
Yeah, I noticed you didn't, but I was hoping that that was the next thing. I read your study.
Yeah. So we did not have discussion, nor did we analyze data.
Do you think there's a way we can get to that data quickly, promptly, easily?
Well, I believe VA has a cost accounting system that assigns costs to encounters for patients and by provider. So I do believe that there's a way to analyze that data.
I was thinking of you in your role as an auditor. Would you just take that data, or would you'd be auditing that, right?
Well, I think the way we normally approach things is we look at data, but then we also look at it in the context of
how it's gathered.
The environment. We talk to the physicians, the management, to understand what the data represents, how it's collected, to make sure that we're able.
Because we're so short on time, I'm going to cut you off. But I want to say that cost of deliverables is a number that's important. I think it's important to me, and I think it's important to the VA as well. Dr. Perlin, you highlighted that some of the biggest challenges the VA faces are with external benchmarking, and I thank you also for your testimony, and I would be remiss if I didn't slip a kudo in for you for my partner, Mr. Pollock, a member from Maine, who usually sits on my right side. The comment on prompt payment of external providers would be, is of concern and would be something where legislative relief would be helpful. Do you have a quick answer on how legislative relief that you would recommend for that?
Yep. Thank you very much for that question. Right now, VA is grappling with 8 different, as I understand it, different payment mechanisms for care outside of the VA. As well, it's really administered as a benefits program, not a reimbursement program, as most of the transactions are, whether they're with Medicare and other governmental payers or whether they're with commercial insurance. So giving VA the tools to actually work more in that domain would be inherently more efficient and would allow that interaction to be much more seamless, and I believe as a derivative that would allow
I would
better.
love to hear your comments offline, perhaps separately, about what we can do to really relieve that problem, and because we're all anxious to relieve that problem along with many others. You also said that there are times when it's inefficient or inappropriate for the VA to internally produce all of the care veterans need, whether for geographic wait times, capacity, or demonstrated clinical performance excellence or technology that just wasn't available in the local VA. Does this sound like the choice program to you?
I think those are elements of the choice program, but really those are the Secretary's words that relate to the reasons to get care outside. No health system can be all things to all people perfectly in all places. VA is remarkable in terms of caring for incredibly complex, vulnerable patients, provides glue and continuity, but certain services clearly would be more efficient in other environments.
Thank you. And as relates to the external benchmarking, I love that part of your testimony. You said it's obligatory to look at productivity and quality simultaneously, and I would like that also to be, the external benchmarking to be kind of marched over to that area as well, because I've worked in VAs and HCAs, and I see differences. Mr. Chairman, I yield back. Thank you.
Mr. Toscano, you're now recognized.
Thank you, Mr. Chairman. I have a question for the GAO, and wanted the GAO report, or the GAO's report highlighted the VA central office, that the VA central office does not require the VA medical centers to monitor efficiency models or to address inefficiencies identified by them. It only encourages them to do so. Mr. Williamson, can you talk a bit about the challenges that this creates?
Sure. Oversight and accountability seem to be endemic in VA for a lot of areas. This is certainly one of them. We have OPES reports data on efficiency, for example, and VAMCs basically, at least the ones we visited, are basically ignoring that because there's no incentive for them. Nobody's held accountable. They don't have to provide any remediation plans. It's data that's out there, and those facilities that take it seriously probably do something. But again, there's a raft of data that OPES puts out there, and it is a lot of the VAMCs don't have the capability or the technical capability or the capacity to do that. But incentivizing it, a good example is the SAIL data, which you're familiar with. There's a star rating system. There's 5 things that are measured in terms of quality, access, patient satisfaction, productivity, and efficiency. Productivity and efficiency are excluded from that star rating, so they're not part of that data. The data is there and it's reported, but it's not. And that star rating system is in part used for performance pay for the leadership of each VAMC. So it's a serious problem.
The VA does have, the central office does have the authority to, well, that's my question. It has the authority to go further than encouraging them? Does it have the authority to mandate it or to direct them to do that?
They have that authority. I would hope the Deputy Undersecretary for Health for Operations has that authority, and I think that in Dr. Clancy's testimony that she indicated they're going to take more of a role in that, but I would like to see that.
Well, the GA also observed that the central office does not have a systemic process in place to monitor these efforts, that the medical centers and the VISNs are not required to submit remediation plans to the central office. nor does the policy state that visits or the central office must monitor the implementation of the remediation plans. In your opinion, without direct oversight from the VA central office, are best practices being identified, actually?
I don't think so. I think it could be better because without some kind of clearinghouse beyond the VISN level that allows you to share best practices, it's very difficult. And you know, VA talks about weekly meetings and monthly meetings where they talk about these things, but a lot of times those may not be well attended. There's no assurance that those best practices are out there. Probably needs to be a little more formalized, in my opinion.
All right. Well, it's kind of interesting to see this amazing sort of relationship between the central office and the medical centers. I'm kind of surprised myself to learn this, but I yield back, Mr. Chairman.
Mr. Bilirakis, you're now recognized.
Thank you, Mr. Chairman. I appreciate it very much. Thank you to the panel for your testimony as well. A lot of my questions were already answered, but Dr. Clancy, you testified that the VA is in the midst of developing standards for advanced practice providers. When can you expect those standards to be released?
Does that work? Sorry, I've never done that before. I believe we have committed to it later this year. I want to just emphasize that this is an area where we don't have external benchmarks to refer to very easily, because historically the work of physician assistants, advanced practice nurses, and so forth has been subsumed under the billing by physician. So we can't easily turn to another large system and say, what are the standards? So to some extent, we will be, I think, as the ranking member noted earlier, in the lead on this particular area, and may end up being a reference for others.
Can you please follow up with that with me? I appreciate that. Let me ask a question with regard to Dr. Perlin, with regard to medical scribes. Are you using, you're familiar obviously with medical scribes, you're using medical scribes within the HCA system?
We have scribes in certain environments. It's not consistent, but it is part of certain practices.
Would you recommend that they be used within the VA? Now, I know to a certain extent, I want to ask this question to the VA too. You know, are we using medical scribes within the VA, and to what extent?
Take that.
I know we are using them in some facilities. I'd have to get back to you with a more robust answer in terms of
Why wouldn't they be widespread in the system? I mean, I know there's several advantages to that. Are there any drawbacks? Why don't we have them in place within the entire system? And I want you to elaborate also, Dr. Perlin, on what the use, how beneficial they are.
Maybe start by providing context. They sometimes relieve the physician or other provider of the burden of entering the information. It's an individual choice. There are providers who are very proficient with electronic health records, myself included, for whom it'd actually be an inefficiency in terms of working through someone else. The other inefficiency that they can offer is that one of the best parts of electronic records is that they can provide decision support, and that decision support is kind of hard to intermediate by someone who tells you, oh, we got this warning for this. So there may be circumstances where efficiency can be increased, certainly for some surgical specialties where someone can serve that function as well. There may be situations in which advanced practitioners who accompany those surgeons or other providers may add that efficiency. But I think the broader question, the one you're getting at that I think is so important, is how do you just increase the efficiency of both the individual provider as well as the overall team?
Yeah, and Dr. Clancy, again, if a physician within the VA requests a scribe, are they readily available? And why not, if they're not available?
So I would agree with Dr. Perlin that scribes are one very specific and very helpful tool for increasing efficiency. In other cases, there's a whole lot of else that we could be doing in a practice. In one of our networks, the network that includes most of Pennsylvania, they have recently begun using scribes and have seen dramatic increases in efficiency and are actually going to be bringing their lessons learned back to share with others. In one recent thing that we did, and I have to look at the other chairman for a moment, recently was to actually go through our view alerts and figure out how could we get rid of some of those that are actually a huge distraction in preventing physicians from seeing the most important messages. And as a result of this system-wide effort, we were actually able to give back about an hour and a half a week to primary care physicians, which again is another increase in efficiency and frankly decrease in sort of irritation, if you will. I'd be happy to make sure that we get you better information on how the scribes are used. I think, as Dr. Perlin said, it's often an individual choice and maybe competing with resources for other types of support for the team in the practice. Do you use them at Cleveland?
Very, very little. There's very little use in Cleveland of scribes. The providers will record it on the electronic medical record, and we extensively use voice recognition software so that reports can be dictated by the providers.
All right, thank you very much. I yield back, Mr. Chairman.
I'm going to indulge Chairman Rowe. If we may, we'll have one more round of questions if we have time with Mr. Correa to be recognized. But I know we have this room is going to be occupied shortly. And just,
So will it be quick?
It'll be quick. Yeah, Mr. Correa, you're now recognized.
Dr. O, if you'd like to go, go ahead, sir. You said quick? Please.
Okay. I will just, I think Dr. Winstrup and others and Dr. Dunn, others of us have practiced medicine for a long time, have seen a lot of the joy leave medicine, and most of it is just checking boxes. I call that polyboxia, where you just check all these boxes, and if you check the right boxes, you're a good doctor, and if you don't, you're a bad doctor, no matter how your patient actually ends up. And it's a source of great frustration, both inside the VA, and you mentioned, Dr. Clancy, the number of prompts that my friends are at the VA, sometimes 200 a day. That's so distracting. You can't possibly practice if you're doing that. I think that we're going to see the use of medical scribes more and more, and certainly in some places, they can be very efficient. I talked to a group of ophthalmologists in a community not too far from mine where there were 5 of them. They all use 1 or 2 scribes. I see 5 doctors see 55,000 patients a year. And I know that when I started in electronic, we put an electronic health record in our office. It slowed me down. I saw less patients and extended my day. That was really wonderful. And it was really, I couldn't tell much benefit. I think it's gotten better. I think the EHRs have gotten better. But certainly at the VA, and I've heard Dr. Winstrup say this many, many times, about if we only saw as few patients as most primary care doctors do at the VA, we could just lock the door and leave because you couldn't pay your bills. And in private practice, that's the case. And I believe I'm right, and that's what he's tried to get out about how much does it cost you to actually see a patient at the VA, and quite frankly, it's hard for anybody to quantify that, but we could pretty much tell you in our practice, because at the end of the year, if we paid our bills, how much I got paid. That's not the case at the VA. So we have a bill, and Dr. Winstrup and I have this bill we're going to mark up on Monday, I think it is, that's going to get a pilot program for scribes. I will tell you, in all of the studies I've read, and I've read several of them in urology, general surgery, and others, where they have to see a lot of patients in a day, it's made their practice more enjoyable, and it's made it more efficient. And they've actually done a better job of coding than the doctors do. I did a lousy job of it. No, I did. I didn't like it, and so I didn't do a very good job of it. I think the other thing that you'll be able to do is with this, with better data going in, I think you're going to be able to better manage populations and get better patient outcomes. I really think you'll be able to do that. And is the VA willing to go ahead, I guess I'll ask Dr. Clancy this, if we pass this bill and gets through the Senate, implement a scribe program, and hopefully in the next year or so we'll have an answer, because it shouldn't be hard to get these people hired.
Absolutely. And, frankly, building on what we've already started to see in Pennsylvania, I think it would be terrific.
Okay, I'll yield back.
Mr. Correa, you are now recognized.
Thank you, Mr. Chair. General question to the panel. As we rush to transform the VA, better, leaner, more responsive, we talk about terms such as productivity, efficiency, quality, looking at off-the-shelf systems to try to integrate them. Question to each and every one of you is system integration, information systems. As we look at the Kaisers of the world and we look at the private sector, big challenge in the private sector, of course, is those information systems are not integrated. So the information here doesn't flow to here, so on and so forth. What attention, what are you doing to assure that the VA itself, as you transform it to something better, whatever that may mean, is fully integrated to be responsive to the needs of the patient?
So I think you've, Congressman, it's a great question, and you put your finger on two very, very important issues. A third game changer, I believe, for access and for being responsive to patients is telehealth. Now, we use this a lot in very different ways. We use it for everything from virtual visits to good old-fashioned telephone visits to video encounters with specialists and so forth. And ultimately, I think that we will be doing this in patients' homes. And we do that in some states right now. How much nicer for a patient with PTSD to get his counseling and therapy from his own home rather than driving 3.5 hours to the nearest medical center and so forth. And that's been very, very successful. Historically at VA, it has been really wonderful but sort of separate from all of our other systems. And increasingly in the past year and a half, we have been integrating that with all of our efforts to make sure that we address our top priority of access to care. So I think that is going to be a game changer because in addition to making it much better and much more responsive to what veterans need and want, I mean, navigating our system or any health system is not a joy unto itself. It's also a terrific platform to extend the expertise of specialists who tend to be at some of our larger, more complex medical centers out to the outlying community-based outpatient clinics and so forth.
If I may follow up, what are you doing to make sure that as you come out with this productivity tool that will multiply your ability to reach out at these, people that live out in areas that are difficult for them to come to the VA? What are we doing to make sure that they understand that this is something that is good and not just a cost-cutting measure, and therefore maybe they may think, patients may think that you're sacrificing efficiency for cost savings? Are we following with some surveys, with some actual studies to make sure that in the process to deliver these services, quality is not being sacrificed?
Yes, we are actually surveying veterans to see how well this works for them. In fact, a big fundamental linchpin of our same-day access for urgent mental health or primary care needs has been that may be a face-to-face visit, it may be a virtual visit or phone call or some other way that we're helping you resolve your problem today. But the point is, we're not going to be forcing this on people who don't want it. But by and large, I would say industry experience has been that people, for the most part, really like it a great deal. So you see the Kaisers of the world doing more and more of it.
Thank you very much. I yield the remainder of my time.
Well, as you can tell by the crowd outside, our rent is due, and the new tenants are ready to move in. So we're going to have to conclude, and if I would encourage anyone, if they have any further questions, to please submit them for the record. So at this time, the panel is now excused, and I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, so ordered, and the hearing is now adjourned, and I thank you all for being with us today. Thank you.